this has led to what I think is an exciting phase 3 trial. And every great trial in breast cancer has to have a good acronym. So maybe you can tell us about Contessa.
The Contessa. The Contessa.
As in Tesetaxel.
Tesetaxel.
The Contessa of all clinical trials.
Yeah.
Right. So tell us about Contessa.
Well, Contessa is a ongoing phase 3 that's enrolling very rapidly for patients with ER-positive metastatic breast cancer, because the control arm is single-agent capecitabine. So it really makes sense, you know, to have an ER-positive group of patients.
That's the standard of care.
Yes, the standard of care, exactly right. That's the first thing you go to. And it is with or without the Tesetaxel. And the patients had to have had a prior taxane, you know, because that's the question. You know, is Tesetaxel sufficiently non-cross-resistant enough with other taxanes to make it really be an impactful step forward for patients, in addition to its, you know, the oral advantage, which of course would be very helpful. But, you know, does it really bring improvement in PFS in the setting of prior taxane in the adjuvant or neoadjuvant setting, not in the metastatic setting? But so it's very simple, you know, 1-to-1 randomization with progression-free survival as the primary endpoint. It's full dose capecitabine, you know, in the single arm, and then it is the, I'm so glad, perfect 1650 milligrams per meter squared, 14/7 in divided doses. You know, the 825 BID, which from all of the data and all of the combinations, that really is the perfect dose, and it's enrolling very well without any, you know, issues that have required, you know, adjustment of the protocol. Of course, there's flexibility in dose reduction and such. So very, very nice trial, and I really like the idea that because it's a long half-life, you don't get that same peak effect. And what's cool about that is not only less neuropathy, but less alopecia.
Right.
Really cool.
Yep. Because
in the early phase 1-2 experience of this combination, there wasn't any grade 2 alopecia. Now, in your single arm study, though,
minimal, really minimal.
In terms of grade 2, some grade 1, right, and a little bit of grade 2.
I'm not sure we saw grade 2.
Oh, really?
So, I
wow.
mean, minimal alopecia.
Minimal.
Yeah.
That's awesome. Awesome.
So this is potentially kinder, gentler doublet therapy. I mean, it would be an all oral regimen. Hopefully, control breast cancer longer than CAPE alone. Maybe this would be the patient who I would have otherwise given vinorelbine to. These are patients who are allowed to have up to one prior chemotherapy regimen for their metastatic disease.
That's right. Yeah.
It may be the taxane, or more likely they will have a taxane in the early stage setting.
Yes.
And they may have had a CDK4/6 inhibitor. They don't have to have had it. Right. So this kind of fits with our earlier discussion about, you know, when you need to make that transition from the world of endocrine therapy for your ER-positive, HER2-negative breast cancer. Where do you go? You know, we go to CAPE, but this might offer another attractive option.
Yeah, it'll be interesting. It may be a little reminiscent potentially of the, depending on how good the PFS is, how much better it is in CAPE of the CDKs. We were initially a little reluctant to give everyone a drug that caused some myelosuppression, et cetera. But now, with the incredible improvement in the PFS and the very good tolerability, it's the standard of care. So it'll be interesting to think about whether an oral doublet, maybe not for everybody, of course, but those with a little bit more disease, more symptoms, become the standard of care.
So Joyce, in your JCO paper in 2002, where dosi-CAPE became a new consideration, part of the motivation, I think, for doing that was this preclinical synergy. Taxanes upregulating thymidylate synthase, perhaps making the cells more sensitive to CAPE, et cetera. We do have some preclinical data with Tesi also that I think show the same potential.
Yes, the same synergy between the two really impressive preclinical models where you get some improvement with the single agents, and you put the two together and the curves just go right down to ground basically. It looks very synergistic preclinically. I'm also thinking, of course, I've been long interested in the docetaxel capecitabine combination. I was gratified to see the results from the adjuvant MIND-ACT trial that Fatima Cardosa presented within the last year, looking at a randomization of an anthracycline taxane-based adjuvant therapy versus docetaxel capecitabine in the MIND-ACT trial. It was about 1,350 patients were randomized. It was a secondary question within the MIND-ACT trial. And at least in that trial, there wasn't a difference in terms of that getting that anthracycline in there. That's, and that was a mixed group of patients, mostly ER positive. There were some triple negatives in there. Now, we know that that's not always the case. The ABC trial showed that for triple negative breast cancer patients or ER positives with 4 or more positive nodes, that the anthracycline did make a difference. But for node negative ER positive or 1 to 3 node positive breast cancer patients who need chemotherapy, which increasingly is a smaller group, it was interesting to see that docetaxel cape. So you wonder about an all oral regimen as a possible use, for this Tesetaxel cape combination, if indeed it's a positive trial in the metastatic setting.
Right.